Thanks, SAPA and APNA, for the chance to speak. As most people know, I do like the sound of my own voice, so it's quite fun. I don't think anyone thought about this carefully because fly away Peter, fly away Paul. So Prof. Norse, who's a very bright mind, and I should actually just leave. The talk today is really about nocturnal enuresis. And if I look odd, it's because I can't see myself on the screen. But we're going to talk, hopefully quite simplistically, about nocturnal enuresis. And we're going to start with basic definitions. We all know the old adage of 10% of 5-year-olds, 5% of 10-year-olds bedwet, but there's a little bit more to it. And really, we would accept bedwetting in most kids up until 5 years, but young ladies tend to be more advanced, and under 4 years, I would certainly consider treating some of these kids. Again, important definition, it can be intermittent incontinence, not all the time, but it happens at least once a month for 3 months. Important in terms of treatment and investigation, we need to look at the monosymptomatic, the true nocturnal enuresis versus the non-monosymptomatic, or as I've termed them, maybe polysymptomatic. Again, primary versus secondary, we all know it well. Have you been dry for 6 months or not makes you primary or secondary. So it's not rocket science. If you look at recent studies, actually 15%, not 10% of 5-year-olds are still bedwetting. And there is an impressive remission rate. And that's probably the best treatment we have available to us is time, because there's about a remission rate of 15% per annum. So we look at about 3% of teens and adults, right down to 0.5%, though most of those are probably underreported. Thanks, Marty. So as we said, remission rates, around 15% of 5-year-olds will spontaneously remit. And this is probably the most important information you can give to parents. Is that, yes, there are lots of things that we can try. We're going to go through some of the modes of treatment, but giving them the reassurance that most kids will be dry. It's like kids who don't like texture when they're eating. Very few 16-year-olds are eating squishes. They want a steak and chips. We know quite clearly it's more common in males, and that goes with a family history. And importantly, yes, we need to refer certain patients. I get to see the more difficult ones. But again, referrals to me, I'm not expecting to find any organic pathology. I'm not expecting to find a tethered cord or a duplex kidney with, an abnormally inserted ureter. The pickup rate for organic causes is really low, less than 3%. We know that family history is strongly positive in this group of patients, particularly the boys. And we know from monozygotic twin studies that the same. Like everything in medicine, we're all looking at genetics, and there certainly have been 2 gene loci identified on chromosome 6 and 13. And it's quite interesting that these seem to regulate both bladder capacity as well as urine output at night and affect sleep arousal. And we all know that we talk about the pituitary hasn't matured, the hypothalamus isn't assessing the diurnal pattern and turning on antidiuretic hormone. And this seems to be where those genes are located. History is critically important. I'm not going to dwell on it. You all know that. Looking at that family, what ages dad got dry or mom got dry, and importantly, is it mono or non-mono symptomatic? Really importantly, we need to look at stooling, yes, but I think that's overplayed. We'll chat about it briefly, but also how the patient sleeps. That's critically important, particularly when related to obstructive sleep apnea. Thanks, Marty. What are the associated bedfellows? Look, constipation is always put down as a potential cause for particularly monosymptomatic, and get the rectum dry and empty, then the bladder will have more space. But really it is an overplayed call. If you look at studies, there's actually a very low correlation, and it's more common in non-monosymptomatic. Whereas obstructive sleep apnea or big adenoids, snoring children really is a critical, important piece of information when it comes to looking at those kids, because if you take out their tonsils and adenoids and relieve that OSA, a lot of them, in some studies up to 50%, will then become dry. So it really is important in those cases. And if they don't become dry, they are kids who respond better to medication that affects their sleep or regulates their sleep patterns. There's also a hypothesized reason that the increased need for intrathoracic pressure increases your atrial natriuretic peptide, and that causes polyuria at night and hence a fuller bladder. This is a very busy slide, and I'm really not going to dwell on it. I really put it in here. It's out of a very nice article on enuresis, and it's really for people to refer back to if they need to. When do I investigate? Who do I investigate? And as I said, I'm not going to dwell on it, but it is quite a nice algorithm. I really think it's important when I see a lot of patients, they've been through various hands already, and the patients are quite frustrated. And you need to be real with these patients. There is no quick fix. Often those patients, I'll say to them, look, your kid's been on X treatment, this treatment, we've tried all these things. Let's try and set our goals, as low as possible. Let's try and get them to stay dry when they're on camp. We know that this combination works really well for them most of the time, so they're going to feel confident on it going to a camp. Can we reduce the wet nights and make the burden on the family a little bit less? Because we know the impact of psychologically to the child and the parents who get frustrated and angry, and the cost, particularly in Cape Town at the moment, we're having pouring rain, hence I'm wearing my scarf. It's freezing cold. Getting things dry is really difficult. And it's important that we want to choose a mode of therapy that lasts. You don't want them to be on a treatment for the next year that costs them a fortune, and then they stop and it recurs. So treating intermittently is an option to get those 3 nights where they dry, and also setting the goals appropriately. And how do we choose our treatment? Well, we look at the age of the patient, obviously, the frequency of their micturition. If they're wetting twice a month, leave them alone. Is it a big wetter or a little wetter? That also helps you decide. And what is the motivation of the family? Generally, by the time they get to me, they're motivated. The kids are often don't want to talk about it, they're embarrassed, but you need motivation from both the child and the parents. Let's try and unsimplify things. A little bit of advice, the rule of 2s, people talk about 2/3 of fluid intake in the morning and into the early afternoon. The last fluids are taken 2 hours before bedtime, and you want to try and get them to wee regularly during the day. Get the bladder into a good habit of voiding normally. Again, I'm not going to overemphasize, the dietary and stool softeners, but it is important in those very constipated kids to deal with that issue. Diaries, I don't use a lot of. I use a lot of reward charts would act as diaries, and rewards are not a bad thing. But the reward chart often gives you some information about how many wet nights, etc., without it becoming an issue. Ladder diaries, yes, they've been shown to be useful, but certainly they also emphasize for the child that this is a problem. And so it needs to be done in a subtle way. Urotherapy. I think this is mostly about understanding or giving the patients understanding, both the kids and the parents, about what is normal. So what is a normal bladder capacity? We know, the previous Hoff from many years ago saying that your age plus 2 times 30 gives you a reasonable volume of what the bladder should be. So moms can come to you and say, well, he has 2 tinkles and it's done, or he wets the bed so it drips off the edge. You're getting some idea about what the bladder capacity is. And a normal bladder capacity, explaining it to the parents, also gives them some ideas. Again, push fluids in the AM, decrease in the PM, managing the stooling. And the important thing is reassuring them that this resolves in most cases. 15% remission rate over the years, and time, if nothing else, will allow that to get better. The rewards, as I said, having a chart is important. And again, importantly, the parents get frustrated. They do blame the children. And still to this day, I'll have parents coming in saying, it's a psychological problem. That's why he wets his bed. We know that that's not true. Sometimes they need psychological support for other reasons, or because this is a drama for them, but it isn't the cause of their enuresis. So what is the best medicine? The best medicine is no medicine.
Oh dear, I think Paul is just...
You muted yourself.
Yeah, I think he just stopped his screen. We're just going to give him a second to join again. I'm sure he's going to be back on just now. Pete, maybe you can tell us how long in your clinics you obviously still see a lot of these kids with enuresis?
Yeah, we do, definitely. I think Paul's patient population probably a lot more drama than our population, but no, we do. I was looking at the price of the alarms. The problem is we don't get doesn't get paid for by the government for some reason. We haven't managed to get our pharmacy to pay for alarms. So. Are you back? Okay.
He's back.
I'm back, sorry.
Okay, great. Welcome back. We're very happy you're back.
Thank you. That was a gastroenterologist phoning me. Sorry about that. So enuresis alarms really are effective, and they're very readily available. Obviously, they come at a cost, and in the public sector, that can be an issue. But You can buy them on Takealot, a whole range of different bedwetting alarms, obviously different qualities from really $600 to 2,000 Rand. And the important thing about the bedwetting alarms is they aren't an instant cure. They take time, but the rewards are the sustained dryness. They have at least a 50% success rate, as long as you're compliant with your treatment, i.e. 16 weeks minimum or 14 consecutive dry nights. They don't really work in patients where there are infrequent wetters, where there are underlying behavioral problems, for example, kids with ADHD or other learning and behavioral problems, and particularly in patients who have untreated lower urinary tract symptoms. And it really is important in this group to emphasize the compliance in these kids. Thanks, Marty. So let's go through some of the drugs, and hopefully I can teach you about some of the newer drugs that are available. We all know DDAVP well, an antidiuretic analog, very successful, particularly in the polyuric Enuretics. The wafer is a fantastic innovation, and it really has made a big difference, particularly in patients where the nasal preparations were affected by allergic rhinitis, or the oral preparations really affected by food. We know that it's going in when they get the wafer. We know that they have about a 30% full response rate, particularly in those polyurics, with a 40% reduction in volume, which also helps in certain circumstances, particularly when kids are overflowing their nappies. And we should warn them about hyponatremia, though I don't think any of us have ever seen it. Water intoxication is extremely rare. Thanks. If we look at the old bladder relaxants, oxybutynin and ditropan, I certainly don't use in the private sector anymore. It is cheap, that's its advantage, but it's a pretty nasty drug. It's an anticholinergic that does cross the blood-brain barrier, and it really does have a psychological behavioral impact in a lot of kids, and it's something to be avoided. Solifenacin or Visacare, a great drug, more bladder specific. Unfortunately, there is no syrup in South Africa, but crushes very easily. It is bladder specific and has a lot less neuropsychiatric side effects, and works really nicely in combination with DDAVP. There are also numerous generics in the market now, which has brought the price down very nicely. I think when I was at university and training as a pediatrician, imipramine was used widely. It's no longer available, but ethipramine is another tricyclic that really does work quite effectively. The dosing there, 10 to 20 milligrams. Yes, it needs to be kept safe because it is cardiotoxic, and it works best in the patients where there are underlying sleep pattern abnormalities. So often your OSA patients, your obstructive sleep apneas, who've had that relieved or treated, they do well on ethipramine because it does modulate their sleep patterns and that sleep arousal, which is critical for patients to be aware of, to wake up to wet during the night. There are some newer agents in the market. Mirabegron's been around a while. Betmiga, I don't know how much experience people have with it. Also comes in a tablet. It is a beta-3 adrenal receptor agonist, and it really works best in females, and particularly the patients with FUDS, or the old frequency urgency dysuria syndrome, now talked about as bladder dysfunction. And it is a nice drug, and it's a nice option, particularly when patients have bad side effects on the anticholinergics. Tolterodine or detrusitol is new on the market here. It's also an anticholinergic, very similar to oxybutynin. And again, I don't have a lot of experience with it, but have used it in patients where the other drugs have been had side effects that were unacceptable. Combination agents, when you're starting to use multiple agents, probably should be best managed by a specialist. But we're all talking to specialists here. The nephrologists here in the crowd, we know maybe a little bit more, but you guys know plenty. So who do we refer and when do we refer? Certainly the non-monosymptomatic or daytime symptoms or daytime incontinence really do need investigations. Poly and oliguria is talked about in papers. It's not something that I go into in great detail. I think the patients who have oliguria or massive weeing, we're going to be aware of and look for things like diabetes insipidus, etc. Again, lower urinary tract symptoms, frequency, urgency, straining to void or intermittent voiding or interrupted stream are really important for those patients to be referred for urodynamics, even just for a uroflow, to assess how their bladder is functioning. And obviously, any patient who's been dry for 6 months, secondary enuresis, tends to have a higher problematic rate and should be referred earlier. I've mentioned there encopresis. Those kids are obvious, associated psychological problems. And important to emphasize there, and I think a lot of us would be aware, that patients with ADHD or other learning disabilities, often when they're treated with methylphenidate or the newer amphetamines, actually their enuresis resolves. So it's a complicated control process in the brain. Abnormal investigations, ultrasound is probably the most least invasive investigation, but it comes at a cost and really should be saved for patients where you are looking for pathologies. Patients with previous UTIs, particularly febrile UTIs, it's obvious that they do need some investigation. To whom do we refer? It's always that question. Do they go to the nephrologists, and we're in a group of nephrologists and pediatricians here, or does the GP just refer to the pediatrician? Absolutely. Urological referral is important when you think there is an underlying problem. You think this patient's had multiple UTIs, they're probably going to need a scope to have a look at the bladder or assess the bladder, and potentially a sting, obviously, if you think there's vesiculoenteric reflux. But a good starting point is the nephrologist. And often just picking up the phone and having a chat to me or to Pete, will give you some information as to what investigations should be done before the patient arrives at your rooms. And I find particularly useful to have a patient having had an ultrasound with a pre and post MIC, size of bladder, and it gives you a good idea how those patients are emptying and what their bladder capacity is. So it was a quick rush through. I'm sorry for leaving in the middle, and I still can't see myself, so it's quite off-putting. What is the take-home message? It really is important to define, is this primary or secondary? Is it monosymptomatic or non-monosymptomatic, which is really quite difficult terminology, but it's what's deemed to be the appropriate way to define it. History gives you most of the information. And constipation, I think, is overemphasized. And I will admit, in the past, I've spent a lot of time treating constipation to make more room in the pelvis. In my experience, unless it's really severe constipation, it makes very little difference. But obstructive sleep apnea is really an important cause of both nocturnal enuresis and ongoing sleep issues which lead to nocturnal enuresis. The patients who have monosymptomatic nocturnal enuresis, a urine dipsticks in the room is all you really need to do. They don't need anything further than that before you decide to treat them. Reassuring patients is critical, making sure they understand that this is a normal process and that there's a good remission rate per year, and that most kids will remit on their own. Alarms, really useful if you've got them available, or patients can get them because of the sustained effect, where the medications, as you withdraw them, a lot of them will unfortunately relapse into nocturnal enuresis. And that is my bundle. Fly away, Paul.